right, so today we're going to start in on postpartum care for pregnant women. We first need to define the postpartum period. The postpartum period is defined as the period immediately following birth until around 6 weeks postpartum. There's many physical, hormonal, and neurologic changes that occur during this time frame that the mother must go through, and we'll talk about those through this voiceover. First, we're going to focus on the physical adaptations, looking at by body system. Of course, with many of the other considerations with pregnancy, we are going to first talk about reproductive changes. So the first key thing that's going to happen with the reproductive organs was with the uterus. There's going to be a rapid reduction in size following delivery of the infant. You may hear the term subinvolution, and this means that there's a slowing of the descent or the involution of the uterus. So it's subpars, a little bit slower than anticipated. You can see in that picture, we do anticipate that the uterus, the fundus of the uterus decreases in height in relationship to the umbilicus over a period of time. So right after delivery, we anticipate that that fundus is going to be midline and midway between the symphysis pubis and the umbilicus, and would palpate to about the size of a grapefruit. However, around 6 to 12 hours after birth, that uterus is going to enlarge slightly due to the blood clots and some of the support changes as a result of hormones, and it's going to be right around the level of the umbilicus. Following that point, it shrinks by about 1 centimeter a day and descends into the pelvis usually around day 10. It doesn't reach the pre-pregnant size till around 6 weeks, so there's much healing that needs to go on with that uterus. During this process of involution, that hyperplasia that had occurred of the uterine lining and tissue during pregnancy begins to reverse. So that spongy layer of decidua is shed as lochia. So LOCHIA is the flow that occurs as that lining is shed. The remaining layers differentiate and lay a foundation for a new endometrium. Breastfeeding impacts this involution of the uterus as it hastens or speeds up the process, because during breastfeeding there's a release of oxytocin, which helps to continue the contraction of the uterus. Nice thing with evolution there, that we naturally help to contract that uterus and help it to return to normal. If there's any elevation beyond what's expected or deviation of the fundus to one side or the other, that should be investigated. The most common cause for a deviation of the fundus would be a deviation to the right that is generally because of a bladder being distended or too full, so it's pushing on that uterus. The concern with that is that the uterus isn't going to be able to contract adequately and could increase the risk for bleeding. So we want to make sure that that bladder is being emptied on a regular basis. The lochia, that discharge after birth, does follow some standard color changes. Initially, it's very bright red. It's called lochia rubra, and that's the first few days postpartum. It'll then kind of transition gradually to this lochia serosa, and the lochia serosa could last up to 3 weeks postpartum. And then the last stage, or the lochia alba, can start as early as 10 days and can last as long as 6 weeks postpartum, and it's more of the white kind of discharge. So there's lots of things that are contained in this. There's epithelial cells, erythrocytes, leukocytes, bacteria, that decidua lining that's being shed, and then some fetal elements as well from the meconium, lanugo, or vernix could be possible. Small clots are normal to see within this. We worry if it becomes to be larger clots. Things that can affect how long the flow of lochia lasts include breastfeeding, because of that contraction may help to hasten that process. And then parity, so depending on if it's your first baby or maybe your sixth, can impact how long that lasts. Having had a C-section and maybe having some of that decidua removed a little bit more during that surgery process can also decrease the length of the flow of lochia. When we look at measuring, how we measure or document how much blood is being lost, we look at how much is on the pad. And you can see in the diagram here on this slide That a scant amount is a very small, so only on tissue when wiped or less than a 1 inch mark on the peri pad. Light flow, which is the second one, would be less than 4 inches, and you can see it's still pretty light on that peri pad. Moderate is a little bit larger, but still is only about roughly half of that peri pad that is has blood absorbed into it and lochia. A heavy amount is if we saturate a peri pad within 1 hour. So that pad is completely saturated and it's occurred in less than 1 hour. So it's important to note not only what the pad looks like, but when was it changed last. So if you see a scant amount, but the mom just got back from the bathroom, that may not be an adequate reflection of how much blood she's losing over time. So documenting on the frequency and how much gives that better picture over time. The cervix, so the cervix had opened up, dilated, effaced for delivery, and it will begin to close slowly after delivery. It usually is closed essentially by the end of the first week. The vagina post-delivery is edematous. That rugae that we generally see in the vagina areas, those vaginal folds, those are really not visible right away because of that edema and the changes that occurred during delivery. Those begin to return around 3 weeks, and it will return to normal or a new normal around 6 weeks postpartum. Lactation can impact this, so that can change that time frame. This would be a good time frame in doing Kegel exercises to maintain and kind of rebuild some of that muscle strength in that vaginal area. The perineum, there's some initial healing of the laceration and episiotomy site that occurs within the first couple of weeks. It's not fully healed until 4 to 6 weeks, and the difference between those two is that initial healing, we take stitches out, or the dissolvable stitches in this case would dissolve earlier than complete healing has occurred. And so you really have to be careful until that complete healing has happened. Many women will experience some after pains or intermittent uterine contractions as that uterus is kind of contracting down and working on that involution process. These are more common or maybe even more noticeable or stronger in multiparous as opposed to nulliparous women. The other consideration that we want to talk about here on this slide is when do periods return and when can women return to sexual activity, because those are common questions. So return to menstruation usually occurs between 7 to 12 weeks postpartum in non-lactating women. Women who are lactating could experience a delay in return to menstruation, but not always. As far as returning to sexual activity, there's 2 things that need to happen. We want to ensure that healing has occurred before sexual activity is resumed so that there's no increased risk of infection or anything like that. So there's 2 areas that we need to think about for healing. The first is the inside the uterus. And so the healing that occurs as that lining is shed, as that placental site where that came detached is healing. How do we know that healing has occurred in the uterus? And that's when that flow of lochia has stopped. So that tells us that all of that lining has been shed and that uterus is healed. The other healing we need to look for is the perineum to ensure that that has healed. And some of that depends on when did they tear? Did they not tear? Is there any healing that needs to happen in that perineal area? And so that return to intercourse can occur anywhere from 3 to 6 weeks postpartum for most women. We do not necessarily say that women have to wait until their 6-week checkup to get the okay to resume sexual activity, although that is a common consideration that we hear out in the social media or movies or so on. Other changes. So the abdomen, that diastasis recti, if there was a true separation in those muscles, they do not necessarily return to a normal status on their own. And so you can see here, even after healing and postpartum, there's still a little bit of a pouch in somebody that has had a diastasis recti. That abdomen does not completely go back to normal. Stretch marks are also a consideration, and those will gradually fade over time. They do not generally go away completely. The GI system, women can experience some slowed bowels due to that lingering progesterone, and they may need a stool softener. So let's think about which women might really benefit from that stool softener. So what kind of considerations would we want women to not be straining? And the big thing here is we don't want them straining if they've got any kind of incision, or if there's anything that may have slowed their bowels even further than just that lingering progesterone. So women who've had a C-section, because that peristalsis was disrupted, and so they might benefit from a stool softener, as well as not needing to strain against their abdominal incision. Women who had some lacerations in the perineum, especially third or fourth degree, where it extended towards that anal sphincter or through the anal sphincter, those would be very, very essential to those women. In the urinary tract, there is an increase in bladder capacity after delivery, and so there's a risk of overdistension. Part of that contributes because of that increased capacity, but also the swelling or bruising of tissues surrounding that urethra as a result of delivery. So there can be some delayed sensation or lack of sensation that the bladder is full. So making sure that that's being monitored so that that impact on the uterine involution is not impacted. There may also be an increase in urine output as a result of that diuresis and the shifting of fluids. So the blood volume, all of that water retention that occurred, all of those fluids that were needed during the pregnancy are going to start shifting. And so there will be an increase in urine output. That output is greater in conditions where fluid retention was greater, like the example we talked about with preeclampsia. Vital signs. There may be some increase in orthostatic hypotension as those changes are occurring with that blood volume and shifting of fluids. The blood values fluctuate in the first couple of days as those fluids and things are shifting. We do recognize that when we're monitoring the hematocrit in regards to blood loss, that a 500 milliliter blood loss would account to about a 2 or 3% drop in hematocrit, and that's fairly typical in a normal vaginal delivery. In a normal C-section, you could see about 1,000 milliliter blood loss. So there is kind of an anticipated drop in hematocrit from a normal delivery, but there's also, if we have a delivery with a high amount of blood loss, then we might see an even more significant drop in hematocrit. So that would be something that could be monitored. That cardiovascular system, initially there's some hypervolemia in absence of the placenta, so that blood volume has increased to ensure that it was circulating through the placenta, but now there is no placenta to circulate through, so there's going to be a little bit of a change. So that cardiac output's still going to need to meet that. You're going to see some fluid shifting, and all of those things kind of return to normal around 6 to 12 weeks postpartum. Some neurologic changes that can occur. Women may experience some headaches postpartum, and there's many factors as listed there. Sometimes from a spinal or an epidural, sometimes related to some fluid imbalances, which you can see here fairly evident. The stress of delivery and having a newborn or PIH can all be factors for that. Another thing that can happen is some postpartum chill or tremors that can occur in women. And those are just, again, those hormones and that fluctuation and all of those changes that are going on. And those tend to be more common in the very early stages postpartum. Next, we're going to talk a little bit about initiation of breastfeeding and how the breasts prepare for lactation. So lactogenesis is the process by which lactation is started. So initially, lactation is under endocrine control. During pregnancy, the initiation of lactation is suppressed by the level of progesterone that's present during pregnancy. After that placenta is expelled, those falling progesterone levels trigger the milk production to begin. So the progesterone has triggered milk production, and then following that trigger, the breast should be stimulated. And if they're stimulated, the prolactin will continue to be produced. If there's no stimulation, then prolactin levels will drop. So let's talk a little bit about prolactin. Prolactin comes from the anterior pituitary gland, and the amount of prolactin rises during pregnancy. Continued production of this is stimulated by suckling or a breast pump. So any kind of stimulation. If we go even greater than 3 hours between feedings, the levels of prolactin will start to decrease. The prolactin is really, really important because initially in those very first 2 weeks of breastfeeding, they're so very important because that prolactin and that continued repeated suckling establishes these receptors that then are needed for continuation of successful breastfeeding. So we really want frequent stimulation to allow that prolactin to establish those receptors in those first 2 weeks. Who should not breastfeed? So there's very few women who can't breastfeed as a result of a medical condition. The key one is a positive HIV. So a mother who's HIV positive should not breastfeed. Most other women are completely fine and okay with breastfeeding. Sometimes we hear that breastfeeding wasn't successful or I was unable to, and often that relates to some of these processes that need to happen early on just not happening in an effective manner. So that early stimulation, frequent stimulation in those first 2 weeks to really establish those receptors is key. As that's going on, we have to think about a couple other things. So what happens at the time of the infant nursing or the breast pump stimulating those breasts? So what's going on? So as the infant nurses, there's a letdown reflex that occurs. So that's a milk ejection reflex. And what triggers that reflex is oxytocin that's released from that posterior pituitary gland as a result of the nipple and areola being compressed. So as the baby starts to suckle, it triggers the posterior pituitary to release oxytocin, and that oxytocin helps to contract those milk ducts and eject that milk or cause that letdown to happen. As breastfeeding becomes well established, so those receptors are very well established and things are going really, really well, eventually the prolactin levels will begin to drop, and they will no longer be the key factor that continues successful breastfeeding. What will take over is this feedback inhibitor of lactation. So this feedback inhibitor of lactation is what we consider a negative feedback loop. So essentially, this is because there's a protein that is present in the breast milk. And if that protein sits in those milk ducts for too long, it will trigger a decrease in milk production. So essentially, if the breasts are being emptied on a regular basis, then production will stay the same or will increase if needed. But if breasts are not being emptied on a regular basis, then a decrease in production will be triggered. So that's where it's really, really important to nurse on a regular basis if breastfeeding is wanted to be continued for a period of time. When we talk about the various components of breast milk, you may hear the terms foremilk and hindmilk. So foremilk is high in lactose, high in protein, and low in fat. It's milk that has filled these lactiferous ducts between feedings. There's no fat globules. So when you look at the previous slide and that picture that zoomed in on those inside that milk duct, you see those fat globules kind of cling to the edges of that inside of that milk duct. And so until that letdown reflex has occurred to squeeze those out, those fat globules are not there. So the foremilk or the first milk is more watery. It does really help with some of that thirst. And you can see that in the picture that there's one that looks a little thinner and one that looks a little thinner and more rich. And so the one to the left is the foremilk. Sometimes it can have a bluish tinge, and that's normal. And then the hind milk occurs after that letdown reflex, once those milk ducts have really been squeezed as a result of that oxytocin, and then the fat and those fat globules are released. And so that richness and those nutrients come from it at that point. So a baby that maybe doesn't nurse for a very, very long time may not always get all of that hind milk. So you can see where that might impact growth if they're not nursing long enough. The other things we have to think about are the stages of milk. So stages of milk start with the colostrum. So colostrum begins to be produced during the pregnancy, and it's the first milk that's available to the baby. It's very small in volume, but babies have a very small stomach. They don't need very much. And it's very concentrated in proteins, vitamins, minerals, has some immune properties and antibodies. It's lower in fat and lactose, and it also has a laxative effect to trigger those bowels to start moving in that infant. Transitional milk begins to come in 2 to 5 days postpartum. So this is when mom might feel her milk coming in. As that transitional milk is occurring, there's an increase in fat, lactose, vitamins, and calories. And mom may notice a few changes as that milk is coming in. The breast may enlarge further as a result of an increase in milk in those milk ducts, but also because those milk ducts are not full, some of those surrounding tissues are unsure of how to take that. So those tissues might be swollen as a result of the milk ducts being filled with milk. So we can kind of help mom with some of that discomfort early on in making sure that that tissue discomfort is eased. One consideration that we do want to think about is as the breast kind of adjusts to that milk being present in the milk ducts, some of that tissue swelling will go away. Moms sometimes are concerned with that, thinking that they're no longer producing milk, but so it's really important to educate them that some of that tissue swelling will go down, and that's normal. It doesn't necessarily mean that the milk has been impacted. That mature milk then, so that transitional is kind of the colostrum mixed with the mature. We fully transition and call it mature milk around 2 weeks, and that's that white to blue tinge in color, and you kind of saw some of that in the for milk, hind milk slide. And that will continue until cessation of breastfeeding. Postpartum nutrition. So I'm going to switch to the next slide and we'll talk about the couple different considerations. So with formula feeding mothers, their nutrition would need to return to the pre-pregnancy intake. So during pregnancy, they needed 300 calories more a day than when they were not pregnant. And so they would reduce back to that pre-pregnancy intake. Occasionally, we may need to do some coaching if there was excessive weight gain on how to reduce calories to facilitate weight loss and return to pre-pregnancy weight. For moms who are breastfeeding, they actually need 500 calories more than when they were not pregnant. And so it's very, very important because those extra calories produce that breast milk. So mom's taking in the calories not only for herself, but also for baby. Need to ensure that there's adequate protein intake, and also the most essential is fluid intake. Without adequate fluids, we cannot produce adequate breast milk. And so dehydration will be a key in triggering a decrease in breast milk. Things that you might take for congestion to kind of dry up your sinuses and things like that, those are going to impact your breast milk because of it dries up some fluid. And so those would want to be avoided as well because we want to keep that fluid up and that nutrition up. There are a couple alterations that we're going to talk about in pregnancy, and the key one that is a huge focus relates to postpartum hemorrhage. So postpartum hemorrhage can occur for a variety of reasons. The key thing we want to think about is how important it is to assess bleeding regularly in that early postpartum time frame for all clients. In the book, there is a table that lists some various pregnancy and delivery risks and what they may lead to postpartum. And on the next slide, we're going to focus on those that can contribute to some postpartum hemorrhage. So when we think about postpartum hemorrhage, we have to think about what kind of things can cause a postpartum hemorrhage. And so the 4 T's is one way to help to remember these. So of these 4 T's, tone is the most common. So things related to tone. So tone refers to uterine atony or an uncontracted uterus. So there's no tone. And so this can occur for a variety of reasons. But some of the things that might put a mom at risk are over-distension of the uterus during pregnancy, maybe as a result of a multiple gestation pregnancy. Placenta abruption or previa can contribute to some uterine atony. A precipitous delivery or a prolonged delivery can contribute. as well as a difficult birth. So there's a few things that can contribute. The use of magnesium sulfate sometimes in preeclampsia may contribute to some uterine atony. The bladder being too full and displacing that uterus can decrease the tone and can contribute. So several factors that we want to consider. Other things that can lead to a postpartum hemorrhage include thrombin. So thrombin has to do with clotting factors. And so when we think about preeclampsia or even HELLP syndrome, those have used up some of those. The platelets are low. There's some challenges with that. And so there could be a hemorrhage as a result of those low clotting factors. Sepsis could also lead to some thrombin challenges, or any other inherited blood clotting disorders could contribute to postpartum hemorrhage as a result of a thrombin consideration. Trauma can occur, generally we think of things like lacerations or operative deliveries that could fall into this trauma. So the bleeding isn't necessarily right from that uterus, but it could be from a laceration on the cervix that is bleeding or things like that. And so that trauma, we may see some, definitely with all of these as well, we may see some bright red bleeding as opposed to the darker lochia. The tissue reason relates to any retained tissues. So that one would be the key, and that one is the placenta. So we really have talked about how important it is to look at that placenta after delivery to ensure that all of the pieces are there, that something hasn't been retained, because that retained tissue will increase the risk of a postpartum hemorrhage. So what are some of the symptoms we would need to consider if a woman's having a postpartum hemorrhage? We'll likely see some heavy bleeding with some large clots. The fundus would be boggy. So when we're palpating that fundus after delivery, we expect it to be firm. So boggy would be the opposite. They may feel some unusual pelvic discomfort or even fullness because of that buildup of blood in the pelvis. And then the symptoms of that hemorrhage, as it starts to lead towards some hypovolemia, you may see an increase in pulse and a decrease in blood pressure. You also want to watch for a perineal hematoma. If it's related to trauma, you may not see frank blood, but maybe there's a large hematoma forming in that perineal area. It's still hemorrhaging, they're still losing a large amount of blood, it's just not occurring in a frank manner. Also, what you may notice in that previous slide is that when the patient's laying in bed, there was a lot of blood pooled in that uterus that maybe wasn't coming out vaginally yet. But when that woman sits up, she may have a large gush of bleeding that's pretty significant. So really monitoring and seeing when you're massaging that fundus, looking to see what does the flow look like from the vagina during that massage. What are the key things we need to do? Well, in postpartum hemorrhage, our big thing is to prevent. That is the best thing we can do, is prevent a postpartum hemorrhage. Some of the things we do as far as prevention is many women will get oxytocin IV after delivery, or if they had it going during the delivery, will increase the rate to try to keep that uterus clamped down. Early breastfeeding, because it releases oxytocin, that can help with that. Other things we might do is really making sure we're massaging that uterus very regularly, as well as emptying that bladder regularly to prevent atony as a result of those considerations. And then monitoring. So monitoring the pulse ox, monitoring those vital signs for signs of hypovolemic shock. Maintaining IV access if in those early postpartum timeframes to ensure that if we needed access, we had it before hypovolemia sets in. Weighing pads to monitor for the amount of blood loss, monitoring for shock, and then providing some emotional support through that time frame. Maybe if a postpartum hemorrhage occurs, you're going to need to provide emotional support to both the patient and to the family. If a postpartum hemorrhage has occurred, what are some of the things we're going to be doing? So there's several interventions as far as close vital signs, monitoring, labs, administration of blood products, and EKG monitoring. Medications that might be given include oxytocin, methergin, hemabate, Preston E2, or Cytotec. And these are medications that were listed in your OB medications to know early in the semester for your ALE 3. So make sure that you're aware of those different medications and how those might be utilized during a postpartum hemorrhage. Other things that we need to think about that might impact the postpartum period is adoption. So there's some psychosocial considerations for both the birth mother and for the adoptive parents that would be different than the normal postpartum psychosocial considerations. And so really working through thinking about what are their personal needs, because it's going to be unique in every situation. Is it open? Is it not? Does the birth mom want to see the baby? Does she not? There's a lot of questions that need asked to ensure that you're supporting the patient and the adoptive parents in the appropriate way. All right, so assessment and care. So what are some of the things that we're going to do on all postpartum women for our physical assessment and care during that postpartum period? All right, so for physical assessment, we really want to start with the vitals, lungs, and heart. So for vitals, the blood pressure and heart rate are going to be assessed every 15 minutes for 8 times, and then about every 4 hours. Temperature would be every 4 hours times 2, and then every 8 hours. And your bubble heat assessment that we're going to start talking about here, in the first hour after delivery, it's done every 15 minutes, and then every 30 minutes for 1 hour, and then every 4 hours there on out. So what are some of those things that fall into that bubble heat? So the first thing that we're going to talk about is breasts. That's the first B. So assessing size, symmetry, shape. Are they soft or firm? So that could indicate where they're at with that milk coming in process. How do the nipples look? Are there any cracks or soreness as a result of initiation of breastfeeding? And is there colostrum present? The uterus, there's a few things we're going to do, and we're looking at the fundus. So we're going to palpate the location and the firmness of the fundus. If it is not firm, we'll massage it to firm and assess the bleeding with that. One of the best things to do before you assess that uterus is to ensure that the woman is voided before. And you can see in that picture that if that bladder is full, it's displacing that fundus off to the mother's right. And so you would palpate a fundus that's not midline and is higher than expected, and likely not very firm because it's being displaced. Another thing that you might do is assessing the incision if the woman had had a cesarean section. If they had a C-section, you do still need to palpate the fundus. You're just going to be very, very gentle during that process. Bladder is the second B, so assessing when the last void was, and then again assessing for distension, retention, or incontinence because of some of those traumas that can occur in the urethral area. The third B, or last B, is bowel. So when was the last BM? Are they passing gas? Are they distended or having any abdominal pain? And those we're going to assess on all women, but again, there's some key women. If they've had any significant lacerations, if they had a C-section, that bowel assessment is even more important. Moving on, so the L is lochia. How much? So think back to that picture of the pads. What is the color of it? And is there any odor? Because odor might be a consideration for infection. If we suspect hemorrhage, then you're going to weigh those pads. The E of bubble is episiotomy site. So we're looking for any edema, any bruising. The Rita scale that you see here on the slide is a really good way to monitor that episiotomy or laceration, anything that's healing. So looking for redness on the incision, edema, ecchymosis, discharge or drainage that's not related to the vaginal lochia, and then approximation. Those squirt bottles that you see off to the side are very, very good for helping keep that site clean and can be used every time the woman goes to the bathroom, and then padding dry. Holman sign. So women in general with postpartum are at risk for DVT. So that increase in fibrinogen that occurs in a normal pregnancy can increase the risk for DVT. So we would assess for that via Holman sign, looking for any pain with dorsiflexion. and ensure that we're getting them up early to ambulate so that we can prevent any of those concerns. And then emotions, so the E of the he. Assessing for any postpartum depression, and we're going to talk about that further in the semester. Looking at bonding, adjustment, rest and sleep, and kind of all of those emotional adjustments that are occurring during that postpartum time frame. And this last slide again just shows that postpartum assessment bubble he picture. I'm also going to talk about some of the common postpartum complaints and what we might do to help women through some of those. So the first thing that women might notice is that when they go to stand up, they may feel a gush of blood that occurs sometimes. So what would cause a gush of blood? It's not, we don't automatically think postpartum hemorrhage, because in general, even if their uterus is having an adequate tone, there would still be some blood that pools in the vagina or the uterus and then comes out when they stand up because of gravity. So the most common reason for a gush of blood is just because of gravity and the blood pooled in the vagina. So we're going to ensure them that that's often normal, but assess that fundus to ensure that that fundus is firm and that everything seems normal. Passing clots, again, that blood is pooling, and so some small clots will form as that blood pools in that vagina and sits there, and then they may be passed upon rising or sitting. So again, that's generally normal. Night sweats, so that's, you know, as those fluids are shifting, they may experience some night sweats. Those after pains that I talked about as that uterus is contracting down and working on the involution process. And then the other complaint that we often see is a large stomach after birth and failure to lose all weight gained during the pregnancy. And so that's really where we need to educate on where all of the weight comes from during the pregnancy. It's not just baby placenta and amniotic fluid. And so it's going to take a little bit of time to work down. And there was a slide earlier in this presentation that showed that gradual progression towards having a flatter abdomen and the time frame. So some examples that you can help during that education. And that is it for today. Thank you for listening.